I'm with Wolf Mehling. Hi, Wolf.
Hi, Rich.
So you're a medical doctor, and you're also very interested. A lot of your work is about pain and maybe the psychosomatic part of it.
Mm-hmm.
What brought you there?
I think the main driver was my own back pain. When I was 27, and I was a very young physician on the way to become an internist, internal medicine doc in Germany, I had so much back pain that I was in sciatica that everybody wanted to do surgery on me, and I just couldn't believe that at age 27 I have to be crippled in a way by surgery, and had, as a student in medicine, I had read Wilhelm Reich, the of orgasm, and I remembered, wow, there was all this psychological stuff, that they had written about in the 30s, how that is related to muscle tension, for example, and I felt like this back pain has all to do with the muscles. So, and that at that time, then I looked for somebody who could help me other than just surgery, and this was age 27, so not easy. So that brought me, and then my conventional medicine has a lot of issues. At that time, this was in the early 70s, mid-70s, beta blocker was the big thing for the heart, and they made advertisements saying, we know how heart attacks happen, it's all from stress, therefore you have to take beta blockers. And I was so upset, wow, nobody questions, how can you deal with stress in a different way, or get rid of stress, or don't feel stress, or whatever. Everybody thought about pills. So I was frustrated with medicine in that respect, and had my own story, back pain. And that kind of started me doing some search. And I looked for some bioenergetic people, and then I went to Eutony. That's something that is not very well known here, I think. It's Gerda Alexander from Denmark, has a system. And then I found a person who does Middendorf breathwork, and that's what I got into the most then at that time. As a normal young doctor, kind of blown away by, how can they do this with their hands working on my back, and how come that I notice whether the therapist is mentally present or is somewhere absent-minded, and I felt that through my hands.
Wow.
I thought, wow, what does that, how does a medically trained person understand that or explain that? And talking with colleagues, they said, well, you're a little funny, talking about these things. So there was kind of a starting point, and then I had a crisis with my medical career, and I was thinking maybe I should do massage, and then I actually learned in Germany, it's a little different. I learned what osteopaths and chiropractors do. So in Germany it's called manual medicine, and that is becoming kind of a generic term for these approaches, or manual therapy, and even NIH calls it this way now. And as the manual therapists are all totally mechanical, this was not satisfying either, so I got more into, I had a title in Germany. You can do a subspecialty. I was at family medicine, it's a 4-year training, added a subspecialty in manual medicine, and became a teacher for these people, and another subspecialty for psychotherapy. So in Germany I had the title of psychotherapy too.
Okay.
Which is a long training, so in parallel to your work, so you do courses and you have to pass an exam and stuff like that.
Yeah. But so I find myself touched as I hear the story of really that it's coming from a sense of feeling the pain and dealing with the pain that is potentially crippling, where essentially society diagnoses it as something that has to make you in a sort of cripple, and looking for support emotionally in a way, physically, practically, but also emotionally, in seeing that other people have a different conception of it. And looking for a breath of fresh air and finding it in a way, among other things, in something that is about breathing.
Yeah, very much. So I don't know if you know this woman, Ilse Middendorf. She's in some definitions of body-oriented psychotherapy, for example, like George Downing, I don't know if you know that name. He would not consider Middendorf breathwork as psychotherapy because they say we don't actually need to cognitively work up all the emotional, psychological issues. So it's not necessary to verbalize everything that happens.
Yeah.
And they say breath therapy is neither psychotherapy nor somatic therapy. Actually, we have something third. So they say, this is, and as a psychosomatically interested physician, I would say this works right at the interface between the two. It's not just either psychotherapy or, it doesn't follow this dichotomy.
And so, for your own work, where would you position yourself in the spectrum?
Well, my background is, and I kind of cannot really give that up, is medical doctor. I'm a physician. And I see patients coming with suffering symptoms that they look for understanding through a physician approach. So they want to have primarily they want to have a biomechanical explanation and a kind of a physical explanation for their pain. But I can best deal with patients who are open-minded enough to also see that there is a relationship in their lifestyle to this story, that they have a history that kind of comes before this pain started, and that there's some psychological aspects to that pain, at least in the course of the pain and how they perceive it.
Right. So that in a way the population or the way you engage people is a little different from, say, the way a psychotherapist engages it. People don't come to us for a psychological component, they come to you for a pain component.
Yeah. Well, I work at the university here. I have a clinic. I'm seeing patients in clinic. And those patients often have seen all their primary care doctors, orthopedic specialists, spine surgeons, neurosurgeons, all this kind of physical therapists. And then they come and want to hear another opinion from somebody who, this center that I'm working in is called Center for Integrative Medicine. And then they read maybe on the website something about, okay, this is a guy who is looking psychosomatically at pain and has a hands-on approach, so I have like 30 to 60 minutes per patient, and can use, and I frame my approach under the subject of manual medicine. So I offer myself as a medical medicine service provider, as a physician. That's why it's manual medicine, not just manual therapy. And they come to me also expecting that I have neurological examination skills and understand the entire language physicians speak in when they discuss with patients, surgical options, for example, or non-surgical options. So I have that medical background, understand. I've been in spine surgeries, I've seen how they do it. I've assisted in those surgeries. as a physician, you can do that. So I understand a little broader than most physicians what medical options are and what, they don't want to do surgery, for example. That's why they come to me.
Right. So that's, in a way, as an alternative to surgery, the idea that manual medicine...
Anything else.
Yeah.
Anything else.
Yeah. So, say, people you see them for, the session lasts 50 or 60 minutes. Is there a course of treatment where you see them for many sessions? Is the course of treatment mostly something that you do with manual medicine, or is there also some talk and some cognitive aspect to it?
Yeah. Actually, I try to pick the patient up where they are. So it's very different. Some get referred by other physicians who know about our clinic or me. Some come out of their own motivation, and some are expecting me to do a spinal manipulation, and that this breaks through their problem, and then they're done. And some come to me knowing, nothing works, what do you have to offer? And then I say, let's examine you first, let's hear your story. Maybe I can help you, maybe I can try to help you, maybe I cannot help you at all. Some patients come with years of narcotic medications and already had surgery, and then I say, well, I don't have enough time, and not in my, I have only a certain amount of hours per week, and I'm already booked pretty much until the summer. In order for you to get any improvement, you should go to a good body worker or physical therapist. I can maybe give you some names, but that's not what I can do really. And some people I can say, okay, let's do 3 sessions, see where we get, reevaluate, and if they are willing to wait, for example, for 2 months or so before we can set regular appointments once a week or so. I see some patients actually over years, once a week, and I see some patients just sporadically every 4 months, once. It varies a lot, and it varies depending on their stories. Some patients need to get into their body, just to feel their body, and not being manually manipulated. And some people benefit a lot from touch, and some other people need to reframe their thinking. It's very depends on the people, on the person. So, talking with you, I know this. I wasn't so aware of that I have a whole spectrum of options, and people fall on different places on that spectrum.
So, it's very, I think any of us, if we were asked, in a way, would have that same thing of, we behave differently with different people, we have a whole spectrum, and so it feels nice to have that acknowledged in the case of your practice,
Yeah.
So which ones, what would be a good, to get a sense, a flavor of how you work? Understanding that you work very differently with different people in different situations. Could we just take maybe a case that would give us some sense of one of the ways you approach things?
Yeah. So, let's see, there's a guy... the people, very, very, okay, let's say an example. There's a guy coming in, he's 84, 40 years of hip pain, about to go to another orthopedist for another shot into his hip joint. It doesn't really, nothing has helped so far. He has had a bursectomy. There's a bursa on the side of the hip that can cause lots of pain. He has seen all the best surgeons in town. He himself is a professor of history. Runs a big company, kind of one of these learning universities that you can enroll in and get a degree on the internet. Very smart guy, but not that young anymore. So he's in his 80s, totally different generation. I'm for me, it's the generation of my fathers. Comes in with this chronic pain. I say, well, you're funny, you've 40 years of pain. What do you think what I can do? Examine him and find what they call in the physical therapy world a trigger point. I don't know if you know these terms. It's within the muscles. It's a defined local section of a muscle that when you put your finger on and press on it, it causes a radiating pain moving away from the site of the pressure into a space in your body that's kind of distant to that, and it reproduces the pain experience that he is coming for. And in this case, it was tensor fasciae latae. It's kind of a muscle on the side of the leg that was seen to be, with the exam, the main source of pain, which is very similar. Some people call it a muscle that causes a pain that's almost the same as a bursitis. That's why they did the bursa surgery without helping him. This guy comes actually, is a professor, as I say, but he comes very casual with tennis shoes, for example. And, okay, I have him laid down. I have a student with me who's kind of a student following me, trying to learn what we do in this kind of funny medicine we do. And I have him lay on the side, and as he's already an older guy, he has had some experience in how to relax. So he knows somewhat in the face of pain how he can still relax. So by kind of closing his eyes, focusing somewhat on his breathing, and not distracting himself with thoughts, and kind of feeling what's happening and quieting his mind down. So he is an educated guy. He can do that without me coaching him very much. I push in a way shiatsu people would do on this trigger point and have him create a feedback circle with me where I say, well, how do you feel that pain? Where does it radiate? All asking him questions he cannot answer by mental activities. He has to focus on the pain itself in order to answer that question. So he has to go into perception away from thinking in order to keep the conversation going with me. So I help him focus on that pain, perceive that pain, get into details about the pain radiant. One of the details is that what I know that they perceive their pain in an internal space. Their body is kind of has an internal space. There's the external space where the five senses are going to, and then there's the inner sense of your body perceptions. The neurology call that proprioception or interoception. So he has to, and people can realize that if you put this in the right words, that feeling into the inside is feeling into an inner space. And where in that inner space goes this pain? So they try to be more specific and detailed. And while I'm doing this with him in this kind of dialoguing form, all of a sudden he starts to do jerky movements. As if so he was laying on his side, bent hip, bent knees, forward a little bit, like a little embryo laying there. All of a sudden getting jerks in his body, and normally a physician would think, what's going on here? Is that a seizure or something like that? And the student next to me almost freaks out, and I ask that patient, is it uncomfortable? What's happening? No, he says, fully awake, and no, and is it? Then I ask him, is it okay if I keep doing the pain while you're doing these kind of movements? And yeah, he says, okay, we can. It's kind of an exploration that we do together. And he keeps jerking, and I noticed that the tension of that muscle that I push with my fingers, it's a manual touch, softens under my finger.
Mm-hmm.
So I have a perception of a muscle release under my fingers. And then, I'm doing this for more than 30 years now. There is a trained, acquired skill of perception into muscles. So when I started this in the beginning, I didn't feel anything,
Mm-hmm.
This other guy tried to show me, feel it now. Is it different or not? I couldn't feel the difference. Now I can notice when the muscle tension slowly melts in front of my hands, in front of my thumb. So it's not something you can do with tools. You have to really use your own hands for that. And the guy relaxes and says, my pain is 50% less.
Mm-hmm.
Now, it didn't go away, but then the next, he goes home, and it's the first night he can sleep through since 1.5 years or something.
Wow.
Comes back a few days later, or a week or two later, and he reports, he had slept and everything. And I say, okay, let's keep doing it. So I thought you're having this for 40 years, we can't do anything, but it looks like there's an access, there's an approach. Do it again. He jerks again like crazy.
Mm-hmm.
They ask him, now what I would ask, but that's the problem because he's 85 and a man of that generation, going through the wars and everything. Ask him, is there any emotion associated to this jerk?
Mm-hmm.
Do you feel anything but the mechanicality of that jerking? And he says, no, I don't feel anything. Just the jerks. Then I inquire a little longer, and he says, well, the pain started when I became a professor 40 years back at Ohio State University or somewhere in Kentucky or Kansas or, I don't know these days, I'm German. Somewhere in the southern Midwest, kind of a blind spot on my landscape, my map. And he didn't know anybody in this town. He was a lonely professor there, starting all young. And what he did after work was he was running every day with his running shoes that he still kind of wears when he comes. And my idea was that he's running to kind of self-medicate his maybe loneliness or whatever. I asked the student what her perception was as an outsider when she saw this guy jerking there, after she overcame the idea that it might be a seizure.
Mm-hmm.
What does it look like? Asked her,
Mm-hmm.
She said, it looks like a crying baby.
Mm-hmm.
She said that. And I felt, of course, the same. I felt like this is a little kid sitting in front of me who's lonely and helpless and doesn't know what to do. And maybe he was running like crazy in order to get away from his lonely feelings at that time. But this topic we could not talk about. So he was not open to open up the can of worms, of his past and his emotional stories. So in this case, I stayed kind of as a mechanical therapist.
Mm-hmm.
Had all these ideas that were not just mine because I had the student with me, they had the same perceptions. And I thought it was very intriguing to see how a muscle can relax even after 40 years and make a significant change in his pain perception.
Right. So that's a very, very beautiful example. And maybe we can talk a little bit more about it. I guess first, as you said, this is
I didn't do psychotherapy on him.
No, but that's beautiful because as you point out, this is, it's not that you don't do it ever, but in this case you didn't. Mm-hmm. And even though you didn't, the not doing it was informed by your own awareness of psychological factors and keeping the question in your mind very much.
Yes. Mm-hmm.
So
if this guy wouldn't be so busy, if he would be retired, he would have a little more time to come back and do regular visits. We could get maybe somewhere closer to reframing his physical understanding of his pain story.
Yeah, yeah. But so in a way, yes, the first thing that strikes me is even though you did not talk about emotions, it was very present. Mm-hmm. But so I wanted to maybe slow down a little bit and point out some of the things you said about what happened in the session. And I think one is you were talking about, in a way, something that happened at the beginning naturally for him because he had some training in it, but that you would otherwise have done, which is a sense of getting him into more of a relaxation mode.
Yeah, one of the main things is that people coming with pain are not able to focus on their own pain. They say, "Doctor, can you look at my pain?" Mm-hmm. Because they kind of have a default system that is helpful for acute pain to distract themselves from pain. They don't really focus attention on their pain perception. They have ruminating thoughts about it and have kind of a mental access to their pain, and the pain interrupts their daily activities. It's a nuisance that they somehow are forced to focus on against their will, but they don't really want to.
Right.
Then they have a hard time relaxing in the face of pain. So what I'm trying to help them is to be present with pain, mm-hmm. really with a full present moment awareness in their pain perception, and relax at the same time. And that's kind of the biggest challenge kind of for a patient in the medical setting.
Yes. So really what struck me as you were talking about it is that, how to make it possible for them to be present with their pain is there is the part of relaxing. And then there is the part where you continuously direct your attention to the perception, the introception, the proprioception, the inner space, the sensation of pain, as opposed to the story they tell themselves about the pain or the
Yeah. So stories are coming up, of course. That's what bodywork does. When you touch it, it's what. My memory of Wilhelm Reich, that's why he did it, why he used touch or certain postures in order to stimulate memories or to have traumatic or whatever history emerge in consciousness for these people out of the unconscious, how they call it, right? Mm-hmm. So stories show up. People all of a sudden have memories from years back when they walked down the street and there was these other kids from their class making fun of them, behind them. And they come to me for certain pain problems, and every time I work on that pain with them, the same memory comes in their mind. And then they finally tell me about it. Wow, it's so strange, I never have thought about this since 20 years. Or they remember how they walked down the schoolyard, the stairs, and realized, oh Jesus, it's not just play, it's work, this school thing. Mm-hmm. And then this memory comes up when I work on their suboccipital neck tension. So stories come up, of course, and you can do some people just want to talk about these things, and psychotherapy often is happy with having then this showing up, this topic, and then work through it cognitively. I'm not that interested in that, honestly. I love these stories, and I love the richness that comes up, and it colors their experience tremendously and enriches the experience. But my focus actually is more back into staying present within their body. So that's kind of my thinking, rather than in the story. So not the narrative around the symptoms is my goal or my target or my direction I'm going into. It's more their capability of staying present within their body, in the present moment.
And what I'm hearing is
meditators do.
Yes, and what I'm hearing is in staying with present is not so much avoiding the story of, in the sense that the story refers to, in a way, what created the original pain, but I think when you're talking about the relaxing with the pain, is about being able to go directly to feeling the pain, as opposed to mechanisms that are avoiding dealing with the sensation of pain. You're directing people to go exactly where in your body do you feel the pain, how it feels like, not avoiding it.
Exactly. Yeah, just the opposite of avoidance.
Yeah. And what you were describing in the story of this patient is that as you held him to feeling his pain as opposed to avoiding it or talking about it or feeling around it, then came something that was this jerking movement, that was a discharge of some sort, and felt like...
I felt somewhat comfortable in allowing him to do that because of prior experiences with bodywork and bioenergetics. If I wouldn't have had that, I would have kind of shied away from letting that happen. I would try to avoid those kind of things.
Yeah.
Physicians are kind of shocked when they see something like that. What the heck is going on here? They don't want to get into those things. And I felt like, well, if he's comfortable with this happening, let's go for it.
Yes, and that was exemplified by the student who was there, who felt, there's something terrible happening.
Yeah.
But you made room for it, because on the whole you felt that it's not something to be afraid of. It seems to be something that's organically completing what this person needs to be doing.
Right. Yes.
And as it was going on, at some instinctual level, both you and your student had a sense that it gave you the sense of a crying baby.
Yes.
So there was also, in a way, as it was happening, something where there was a connection with some kind of a meaning that it had, or some kind of a completion of something he needed to do.
Yes. And the result was 50% less pain. I mean, this is pretty striking.
That's very striking. That's very striking.
And you can feel it under your thumb.
Yes.
So it's not just a perceptual thing, one-sided on the side of the patient. And what I'm emphasizing is this: when I'm doing this work I use my hands a lot. I don't always push onto pain. Sometimes I just have my hands somewhere in order to allow their attention to be located within their body at a certain area where they, for example, low back pain, they all have the problem that they approach their back pain from the top, from the head down, and don't feel their legs very well, or their buttocks, or their sacrum, underneath the low back pain. Underneath in terms of the standing person, it's closer to the ground. They're not connected to the ground. So I try to guide their internal attention to sensation, like they have sciatic pain, they feel the pain, the leg only as pain. They don't feel presence, that there is some connection to the ground, that they still also have. So I try to guide them into body areas where they can feel their body and be present there. So present moment awareness of immediate real life experiences, how they feel it, and then I noticed, for example, that the feet get warm. They were cold first, and they notice that themselves, and so there's objective changes, and it's part of a dialogue that I'm creating, and I involve them mentally in I give them questions that kind of give them kind of a hook they put their head on. The awareness or their attention goes around in their thinking, in circles, and They didn't get out of it, the psychologists call it rumination.
Mm-hmm, mm-hmm.
That's kind of a psychological factor actually for chronification of pain, or for persistence, or for the prognosis of pain. And that's something you can change immediately. You can get them in the clinic session out of their rumination into present moment awareness. And that's where the hands are extremely helpful. Touch has the additional advantage of guiding attention, or if two people focus attention on a certain part and they meet together, they have contact in that space inside your body where the whole thing is screening in a way for attention.
Right.
If you meet there together, that's a support for their attention. And that's why touch is so powerful. If they only think about these things and you guide them, they can feel this certain area into their body, but then they get into their thoughts and they're out of it. So continuing touch and refocusing is kind of like a red string, like an Ariadne string, through the labyrinth there. So they keep in present moment presence.
So this
thoughts.
You had a very striking image a little earlier. You talk about the pain, a part of the body that's screaming for attention, and that you are helping the patient bring present moment awareness to that part, and you are bringing present moment awareness to that part. You're not a tool, you're not a machine, but there's a very strong sense of you being aware, moment by moment, of your pressure and the reaction of the muscle.
Right. Yes.
So there
has to be myself in present moment awareness, or have to. Actually, my issue is that I'm a thinker myself. I'm not easy in being in present moment awareness. Like right now, I'm talking with you. I'm very present in my body. But using my hands has helped me to become present myself. So I'm actually abusing patience in a way for my own meditation.
Yeah, but
it happens together then. So it's perfect. It's wonderful.
But that's also a very nice touch, in a way, a very nice point to make, that it's not that mindfulness or present moment awareness is something that is an essential quality that defines people, that they have it or don't have it, but it's a practice.
Oh yeah, yeah. It's something that happens. It's the term practice suggests somehow that you can make it or do it. In some way, it's yes, you got to do it, but you also have to let it happen. So yeah, it's kind of it's more emergence and arising rather than doing. But you got to approach it, and you got to focus a little differently than just talking on the phone.
Yeah. So as we're coming toward the end of this conversation, maybe one way I could think of concluding it would be to talk a little bit about body awareness.
Yeah, my research. So I got an NIH grant, to my own surprise, but it was a lot of work to get there. I think I had 2 resubmissions for developing a self-report measure on body awareness. And I'm applying for another grant right now to get an objective measure, a performance measure of breath awareness, which is totally something. Well, it has been used in some way for asthma research, and people never applied that for the body awareness type of stuff. So my interest is, I think that a common denominator of many of these approaches, or a common mediator in those beneficial effects of these techniques, is a training or increase or facilitation of people being in certain mode of body awareness. And body awareness is a term that has been around in medicine only in association with hypervigilance and hypochondriacs and fear and anxiety disorders, panic disorder. People are aware of body symptoms, going to the doctor, are an annoyance to the doctor because the doctor said, well, they're all crazy, they're all anxious, that's it, and they give them sedative drugs or something. And and that's how body awareness has commonly been used, if it was used at all.
It's a problem. It's a problem that has to be cured.
It's a problem, exactly, and it's close to anxiety. It's a proxy for anxiety, and they use scales for how many of those symptoms and how often do you feel all these symptoms, and then they go to a list of 80 symptoms or something, and the more symptoms you feel, the more anxious you are. And then you get on to, there's a cutoff, and then, okay, after this cutoff, you got to do therapy or medication. So it's used as a proxy for anxiety, but the people who do body work or body psychotherapy, they kind of, in their own lingo, use that term body awareness among themselves. Feldenkrais use self-awareness. They don't try to distinguish the body from the self, and they have some problems with the nomenclature there. But in general, if you would say body is not separate from mind and soul, or wherever you frame it, focusing on body sensations, you can talk on body awareness of these people. And yoga, tai chi, focusing, for example, as a psychotherapy form, all this, and Feldenkrais, Alexander work, euphony, sensory awareness. The term is sensory awareness. Gindler work, all these therapies, they all use more or less as a common denominator. They talk about body awareness. Then how they incorporate that into cognitive work, psychology, is different according to the methods, but I think there is a common denominator with the body awareness, and so that's why I kind of try to emphasize that. So I try to create a bridge, also in terminology and language, between the medical world and the world that uses body awareness. So even massage, there's qualitative studies that show that one of the benefits after massage, also it's not educational, is for the moment after the massage you feel more in your body. Or people who just go running as in workup. And my philosophical more understanding is that in our culture today, where we go into computers and virtual reality, movies, narrative stuff, lots of mental thinking, we lose touch with our body. And the trend for getting a massage once a month, or going into yoga classes, or having yoga as the biggest kind of practice happening now these days, or Tai Chi, kind of the second stuff happening on the block, that there's an unconscious trend or emerging that people say there is something missing if I just sit on the computer all day.
Yeah.
And that's what the body demands in a way. And I think that's a wonderful trend, I think, and I'm trying to support research into these methods, how the benefits come about, and the medical community needs to know what is the mechanism of action, and they don't understand. Nobody knows. Why is yoga helpful? And the mechanism of action is the scientific term, kind of, how does it work? And I'm proposing increased body awareness. Okay, what is body awareness? How do you measure that? Nobody can measure that. So medical science, if you want to make a point there, it's not sufficient just to do clinical studies on yoga that they help. You also have to help physicians in wrapping their mind around it. Why does it help? What are they really doing? And the neuroscientists, they come kind of along with this term interoception. And the meditation research, they talk about interoception as part of what's going on when you meditate. So putting these things kind of together, trying to use the language from neuroscience and apply that to stuff that happens with yoga, for example, or body-oriented psychotherapy. I'm interested in doing more studies on breathwork. And I think the perception of breathing is one of the most beautiful and fascinating aspects within body awareness. So that's my goal, to help medicine along. So I'm a physician. I'm dedicated to my group there.
Thanks, Wolf.
You're very welcome.
This recording is part of the Somatic Mindfulness and Relational Psychotherapy podcast. See the website relationalimplicit.com.